This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now. I'll be strong. I'll play my fight song. And I don't really care.
So folks, welcome back to again the new rollout for the Thomas Jefferson EMS Council's medical guidelines. So this time around we have taken care of some other subjects in other videos, and today we're going to talk about children and specifically about neonates, and probably a topic that everybody wants to know about, doesn't ever feel very comfortable about. And I'm sort of reminded of a quote from years ago from the Pixar movie Monsters, Inc., where I think they're talking to Wazowski, and he says, there is nothing more dangerous or scary than a human child. And I think underneath it all, probably some of us all sort of feel that way. Even as parents, children are scary. But anyway, we are joined today by Dr. Elise Paget-Brown, and she's an associate professor of neonatology at the UVA Medical Center and also the medical director for the newborn emergency transport system. Morning.
Good morning, Tom.
Well, we're going to take on the terrible, scary topic of little kids. So kids, the thing that everybody is terrified about, we don't do that much of, and particularly sick kids. And neonatology, as you've pointed out, neonatology specifically, and not pediatrics, is your specialty. Is there really a reason? Why are we so terrified of kids?
I think the main reason we're so terrified of kids is because we never, well, not never, very, very, very rarely see them. And familiarity breeds comfort in whatever skill set you have. And so I can say very, very frankly that I love babies. The smaller they are, the happier and more comfortable I feel, which is probably completely inverse to anybody else watching these videos.
That makes you a freak, you know that?
I know, and I own it. Total freak. But you give me granddad done passed out in the lobby, and that terrifies me beyond belief.
And I think there's probably a good reason for that. I mean, if you look at the whole patient population that EMS take care of, we may see some normal deliveries that occur in a pre-hospital setting, but it's pretty rare that you get a sick newborn baby. And so understandably, that's going to, raise people's anxiety. If you were to sort of reassure everybody and say, look, you don't have to be that scared. There's a couple of things you just really need to know about little babies when things are not going great. What would that be?
I'd have to say there are two things. I like to think of little babies as really one giant lung and one giant vagus nerve. And any sort of vagal stimulation that you're going to apply is going to drop the heart rate no matter what. And if you're going to focus on one thing in your resuscitation, focus on the ventilation and throw in a little oxygenation. But babies in general, especially brand new newborns or babies that have gone home uncomplicated from the hospital, frequently do not have little baby MIs. They don't have little baby STEMIs or strokes. Generally, it's infection or respiratory failure. And you're going to get more bang for your buck by adequately ventilating a baby without mashing on their eyeballs when you're doing so, than in going right in there and starting to think up huge concoctions of medications, chest compressions, and everything else. You're really much better served by spending a good 30 seconds to a minute with any newborn focusing on just the ventilation.
Well, that seems like forever.
It does. It does. But it also goes by really quickly. It's that time warp on any transport or any code. Some things seem like they're taking forever and only 2 minutes have gone by, and other things have gone by like a flash and you realize you've been there 20 minutes.
So if we're talking about neonates for the moment, and I suppose the nightmare situation is the baby who's born at home or born in your ambulance, and it looks like a prune, and it's not moving much, and it's not making any much noise at all. Is it reasonable to say that absent of known problems, we knew nothing about this, was just a precipitous or delivery that we didn't expect, the fact that it's kind of a bit still at the start and kind of purple and not making a whole lot of noise, is that in itself something to make you jump in right away and do something?
Well, Tom, that's something, a little pruny, limp baby that's not doing very much of anything, that's born precipitously, does make you want to do something right away, but it's not jumping and thumping on the chest. and doing chest compressions. The thing you want to do right away is the NRP, which is Neonatal Resuscitation Program, not the National Registry of Paramedics in this case. NRP guidelines say you rush right in and you start to warm, dry, and stimulate the baby. Those are the key things you're going to do, and you're going to do that for 30 seconds to a minute before you even worry about what the heart rate is. And what you're going to do after that, if you warm, dry, and stimulate for 30 seconds, the baby's still limp and not doing anything, you want to start bagging that baby and doing some positive pressure ventilation with a mask and an embu bag. You do that first, and you do that for a solid 30 to 60 seconds before you even really care that the heart rate is low or not, or adequate, and assess it.
So I think one of the things there that the point we probably should bring out is these babies are born, and even, you know, a lot of us are parents, a lot of our own children, they weren't born salmon pink and ready to go to school. I mean, they kind of had a purplish look to them, but that's a very good reason for that, right?
The reason for that, Tom, is that in utero, they are hypoxic. They're getting secondhand blood from mom that's perfusing the placenta, that's giving them secondhand oxygen, and they are functioning in a sort of 15, 18% oxygen as opposed to 21% state. So their saturations in utero around 65-ish% is normal for them. That's what they grew in. And during some of the later stages of labor, it even drops down into the 50s. So it's okay for them to come out purple. It actually has been studied, and it's not until sort of 8 minutes or so of life that they should be above 90% saturated. In fact, my son famously came out purple as a grape, screamed bloody murder for 10 minutes, and it was only by 10 minutes he looked kind of sort of human and pink. It took a while. I kept saying, anytime now, anytime. But it took him a little while, and that's normal. That's completely normal. If the baby's active and screaming and crying, just leave them alone. There's no reason to give extra oxygen in those cases. Just make sure the baby is warm, and the warmth you can do there, if the mama's stable, is just skin to skin. You don't want 3 layers of clothing between wet baby and mommy. You want the baby dried off and directly on her chest. That's the best incubator there is.
So don't get all wild and crazy just because for the first few seconds of life, baby looks like a prune.
No, that's okay, as long as they're screaming and crying.
But there comes a point where we've dried him off and we've stimulated the heck out of him, and he's still kind of purplish looking and he's not making a lot of noise. And we do now have to assess some heart rates, because after this period, then a heart rate very often is our deciding metric. What's the reasonable heart rate where you think, okay, now I really need to compress this baby a little bit?
You only want to start doing chest compressions if the heart rate falls below 60. And you want to stop doing them when the heart rate has risen with your interventions to above 60.
So one thing I keep hearing you say here is you keep talking about ventilation and bagging, and only maybe once or twice have you mentioned oxygen at all. Why?
Well, if you think about it, again, babies were in a hypoxic state, so they're really, really good about scavenging oxygen off of mom, holding on to it well enough, and delivering it to the tissues as needed. Babies with congenital heart disease, before they're repaired, will live with oxygenation sat in the 70s and 80s. That's not to say you shouldn't care about oxygen, but your first 10 minutes of life, really make sure you're ventilating well, and make sure that that's going well. If you're trending towards, I think I need to do chest compressions now, put on some oxygen. I know a lot of folks out there, your choices are generally room air or 100%. If you're starting to do chest compression, put them on 100%.
So really sort of listening to what you're saying there, it's perfectly all right at the start if indeed you decide that the baby needs a little bagging. You're looking to ventilate the kid. So you're looking for the positive pressure, the flow in and out of the child. You can achieve that without any oxygen attached to the bag, as long as there's room air going in and out of it. So in all that, obviously more things than the arrest situation happen. We have changed in the guidelines to put epinephrine above atropine, and that's a change you will see this time around. Was epinephrine better in that situation than atropine? Why should we have changed it?
Atropine and epinephrine would both bring up your heart rate, but the thing about epinephrine, which is good in having it number one, is I'm all for standardization, and if you can use multiple similar guidelines for different age groups, it's wonderful. And epinephrine is the first line now for both bigger children and for the very little people that I deal with. I think that simplifies it for the care provider, and because the dosage is going to be similar in terms of micrograms per kilo, milligrams per kilo, and so I think it's very reasonable to do that.
So we go to lots and lots of different places nowadays. Times have changed. Babies are not just born at home or in the hospital, and most all born in the hospital. But there are all sorts of interim level places that have popped up over the years, and birthing centers and what have you. And we go there. And when things are not going particularly as planned, they will call us. And the same to pediatric clinics, it's not just neonates. So if you're trying to think of how we can most smoothly interface with all those people, because knowing, I think it's fair to say that neonatologists and pediatric folks, as a group, I found are phenomenally protective of their little people. And so as a result, sometimes that interface can be a little tense. First, clinically, what are the things, regardless of where you go, that you need to have in place before you move a kid or a little baby? And also, how do you think we can get that interface to work best with these other places that didn't previously exist, birthing centers and what have you?
I think the best things that we can do, firstly, is being prepared. When you're being dispatched, if you're being dispatched for a baby, you know you're going to a birthing center and it's going to be a baby. Even if you have to have a cheat sheet of what the, what the protocols are, look them up on your phone, have them on your badge, something along those lines. Run through, okay, this is a baby, this isn't PALS and 15-2 respiration compressions, or compression to respirations, this is a baby, it's going to be 3-1. Refresh your memory about what the drug dosages are and what you're going to need to do if you need to intervene with that child or that baby. And then when you get there, it's important, I think, to take a breath, identify whoever the lead care provider is that you're going to receive information from, and listen to their side of the story. It should only take 30 seconds or so. Then also to remember that if it's something that feels truly out of the ordinary, that folks aren't comfortable dealing with, that there are other resources and specialty care teams that are available that can help with an assist if needed, bearing in mind that this is going to take a little extra time to get there.
So when we get to drawn to towards the end of this, one of the things I think, if you're certainly in an agency that's close to the city here, you see more and more babies being discharged out into the community. They're probably sicker babies, sicker children than you did before, because there's a specialty resource center here and folks can live, so to speak, fairly independently and not be 3, 4, 5 hours away from the specialty resource that these kids need. Let me ask you this. If you were just looking at the population and you're on that end where these youngsters that have problems and continue to have a problem, but they're okay now to get sent out, they stay locally in the community. If you were an EMS provider, because as EMS people, we're always scared to get caught off guard. The last thing, we hate surprises. Yep, we work in surprises all the time, I don't know. But the things that are out there that you would tell me here, Tom, you really need to read up a little bit on them, because they're out there a lot, and there's a big chance they'll catch you because they're out in the community. What sort of things are they being?
Well, there are a lot of kids out there, Tom, that have special medical needs. Those range from quite a number of repaired or palliated, so having stage 1 or 2 of a multi-step repair of congenital heart disease. And those kids can present with all sorts of crazy rhythm anomalies and other medical needs. So if they get sick or whatever, they get dehydrated, their electrolytes shoot out of whack, the medications they're on. You can have some of the chronic lung disease babies that some of our former preemies that go home with ventilators. That as we get towards different viral seasons of the year can really suffer, or if even they get the common cold any time of the year, can really be thrown for a loop. We also have a range of kids, from dialysis kids that are out there and can have infections, can have dialysis electrolyte problems, We have a lot of cancer patients, unfortunately, but we have a lot of pediatric cancer patients that are potentially affected by sepsis, by any sort of electrolyte or white cell, red cell anomalies. So reading up on some of the heart lesions, congenital heart lesions, and some of the repair, some of the rhythm stuff is probably a good way to go. As well as having in your mind, what are my protocols for sepsis? What are my protocols for fluid boluses? What do I need to look at? How about the glucoses with some of the kids with diabetes in the community? Things like that, although the diabetics are probably a little bit more similar to slightly bigger people and how you deal with that. But things like that I think is probably most important. The other thing to remember, Tom, is some of the babies that we see that are happy babies that went home from the newborn nursery and look great, look fine. Hopefully we have fewer of this particular population, the ones that go home with undiagnosed heart disease, congenital heart disease. They're the ones that have a ductus arteriosus in utero, which they're supposed to have, but when that closes, that can really throw them for a loop. And they can look, for all intents and purposes, like septic babies, but it's to keep in the back of your mind. They will come in, they'll be shocky, gray, mottled, usually around 2 weeks of age, anywhere between 1 and 3 weeks of age. And yes, you're going to probably treat them with fluid boluses and getting them to the hospital as quickly as possible. But have in the back of your mind, is this a ductal lesion that's closing, ductal dependent lesion that's closing? And could that be a problem?
So one of the things too as well that we need to remember, I know we keep saying this over and over, but in a crisis type situation, especially with these kids that have been discharged from the hospital, they have no medical problems. They're so they have close proximity to the medical center. Very often, mom and dad are the experts in the room, and there's wonderful information to be got from them. Would you agree that it's probably a good resource to try and get that from mom and dad? They've been with this child through his care or her care, and not to forget to use that great resource is right in the room with you.
I completely agree, Tom. Mom and dad are a wonderful resource. They usually have that information on their child and the past medical history.
So there you go, Trip Through Scary Kids. I'd like to thank Dr. Elise Paget-Brown for coming and spending her time with us today. Also, of course, thank the folks again that have helped us do this, Hoopla Media, and very specially Lifecare Medical Transports, who sponsored us financially so as we could do it. We'll be back. We'll do some more with medical cases the next time, and I hope you'll join us. Thanks.